Can you hear us now? They can. All right, great. Thank you. All right, so I'll be presenting an interesting 5-minute case. This is a 56-year-old man who came to see us for progressive weakness and increased falls. It had started around 2015, so it had been going on for about 8 years. He had difficulty going up the stairs, but also weakness in his arms, legs, neck, and back, and was having frequent falls at the time. He also had developed shortness of breath, orthopnea, and dysphagia, as well as numbness in his feet for several years of unknown etiology. And the right side of his face would intermittently contract, and it was numb. And at one point, they thought it was a stroke. On our examination, he had reduced sensation in the right V1 to V3 distribution, a little bit of eye closure weakness, and then very severe cheek puff weakness and tongue atrophy. And then motor-wise, he had diffuse bulk loss and fasciculation and weakness that was most prominent proximally. Sensory-wise, there was mildly reduced sensation and temperature in the toes. All of his reflexes were absent, and there were no pathological reflexes, and he needed a cane to ambulate and had a waddling gait. So we saw him in the EMG lab, and these are the nerve conductions here. So this is the motor nerve conduction, and the green is normal and the yellow is abnormal. So we can see that the right facial motor nerve is affected. There's no response there on the right, but the left seems okay. And then the fibular to the EDB muscle motor response had a reduced amplitude, but normal distal latency and conduction velocity. So it seems like this is a motor axonal process, not clearly length dependent, because the facial nerve was involved too. And then these are the sensory responses, and he does have a relatively moderately severe sensory neuropathy, because the sural is affected, as well as the ulnar and all the way up to the radial sensory. So definitely has a sensory process going on as well. Sorry, should be EMG, not blink reflexes. But so on his EMG, he had abnormalities in all the muscles we tested, reinnervation changes and signs of ongoing denervation. And they were very prominent in the craniobulbar muscles. The masseter had pretty huge amplitude motor unit potentials. So this has been going on for a while. So the differential diagnosis at this point was either ALS with a polyneuropathy, although he didn't really have upper motor neuron signs, an entity called facial onset sensory and motor neuronopathy. And we thought of that because of the facial symptoms of weakness and numbness, and possibly what was called a stroke. And this is a variant of ALS. And then Kennedy's disease, or spinal bulbar muscular atrophy, which is a lower motor neuron hereditary process. So we saw Dr. Gonzalez, one of our neuromuscular specialists in clinic, and she sent this test, which came back positive. So this was a genetic test for Kennedy's disease, and he had 42 CAG repeats. So Kennedy's disease is a rare X-linked hereditary lower motor neuron disease. It's caused by an expanded trinucleotide repeat in the androgen receptor gene, and you need more than 37 repeats to be pathological. In addition to the lower motor neuron disease, non-neurological manifestations include gynecomastia, testicular atrophy, reduced fertility, and erectile dysfunction because of the androgen receptor gene being involved. But luckily, life expectancy is not significantly altered the way it is with ALS. Sensory impairment is actually present more than one might think. So if you test patients, the sensory impairment is present in 44%, but only 16% report numbness and tingling in the feet. And then on nerve conduction tests, a very high proportion of patients have loss of sensory nerve amplitude potentials, and blink reflexes, which I didn't include, are also altered as they were in our patients. So the take-home message is, think of so Kennedy's disease is a progressive sensory motor neuronopathy, and you should consider this diagnosis if you have a patient who has only lower motor neuron signs without upper motor neuron signs, unexplained sensory abnormalities or sensory neuropathy, facial fasciculation, which was a big hint in this patient, and also a male patient since it's X-linked. So thank you.
Great work. Thank you for doing that. I was just going to share the CME code for today is KABTOZ, CABTOZ, KABTOZ. It's in the chat.
Okay, so we move forward now, right? Is it? Sorry. I move forward with it. Okay, great. Okay. So it's my honor to be able to present Scott Kasner today. So Scott ran the stroke service, the Comprehensive Stroke Center for many decades at Penn. He's the chief of stroke there. Now I should come clean and say that I've known Scott for about 30 years. We did our residency together at Penn. And there's a certain bias when you know someone and you're friends with them and you present them. So I thought I would go to an objective source, that is ChatGPT, to see what they says about Scott. And this should be a cautionary measure for everyone who uses ChatGPT without fact checking. So it starts out well. It's my honor to introduce to you our esteemed speaker for today, Dr. Scott Kasner. Throughout his career, Dr. Kasner has been recognized for his groundbreaking research in stroke and other vascular disorders. So far, so good. And then it goes off the rails a little bit. Dr. Kasner is a graduate of Harvard Medical School, where he received his medical degree. He completed his residency in neurology at Mass General Hospital and a fellowship in vascular neurology at the University of California, San Francisco, all of which is entirely plausible and sounds good, but not a word of that is true. So Scott, I believe you went to Duke undergraduate, Yale Medical School, Penn residency, and did your fellowship with Jim Grata in Texas. So anyway, it's a cautionary measure when you use ChatGPT, be careful. What is true is that Scott has been unbelievably prolific. He's been involved in just about every major study that's influenced how we think about stroke in terms of prognosis and intervention, especially cryptogenic stroke, which he's going to talk about today. So, is this what's being broadcast here? Is that Will? Okay, we see Will.
Sorry about that.
But perhaps more importantly, and something, Scott, I've never said to you, but I totally share your passion for mentorship. So Scott serves as vice chair and has mentored a whole generation of people who will be our future stroke neurologists. So it really is a pleasure to introduce Scott, my friend and a preeminent stroke neurologist, talking about cryptogenic stroke. So
awesome. Well, thank you so much. It's really a pleasure and honor to be here. I guess I probably shouldn't have used ChatGPT to make my slides. All right, let's see if I can share my screen here. Looks like we're good to go. Some weird thing happening with the mouse, actually. This is really weird. We lost our AV guy too, right? See if I can make this work here. All right. And my slides are being shared, I hope. They're not. Go back to Zoom, hit share screen first. Okay, share that, and then try to make, oh, there's my, okay. All right, I think now we're good. All right, so I'm going to talk about a topic that's hard to talk about, cryptogenic stroke, which is something we're struggling to define and yet a major clinical problem, and trying to figure out a path to understanding this disease and most importantly, how to prevent it from happening. So here are some disclosures. Just state specifically that there are no medications approved for embolic stroke of undetermined source or cryptogenic stroke here or in any country. Again, I'm a prior Duke Blue Devil, so I guess that's a disclosure. So when we think about ischemic stroke, we typically divide them into 5 categories based on a prior trial called TOAST. What that stands for is not so important, but we define stroke as either due to large vessel disease, small vessel disease, cardioembolism, other atypical causes, or cryptogenic. Cryptogenic here is the big gray area, literally and figuratively, and is the thing that we're talking about today. And it's important to define this because when we think about stroke prevention, the first question we ask is, what was the cause of the index stroke? And we're going to choose specific therapies based on that to prevent the next. Revascularization for large vessel disease, antiplatelet therapy for small vessel disease, anticoagulation for cardioembolism. And then, of course, some generic stuff like risk factor modification, lifestyle modification, statins, et cetera. When we think about the other determined causes of stroke, that list keeps growing. And so that helps narrow the playing field a little bit. Some of them are well known to us. Some of them are relatively new, like carotid webs, and some evolving research in genetic disorders and prothrombotic disorders. If we find one of these other causes of stroke, again, then we can say sometimes we have a specific therapy for them. Not always, but if they have underlying carotid web, you could theoretically treat that. How best to do that is still debated. But again, specific therapies for specific causes. But then we're left with this big gray zone, and we don't know what to do with them. And if we don't know what causes them, then how do we treat them? So where did they come from? These cryptogenic strokes. Tales from the crypt, some deep dark mystery crawling out of the grave. Well, that's probably not it. So we need to have a more logical approach to managing and defining this disease. So here begins my Star Trek obsession in this talk. Again, if we don't know the cause, then we don't know the treatment. So what is cryptogenic stroke? Well, in the criteria, in this TOAST criteria and another prior criteria for defining stroke, this cryptogenic stroke category included mainly three categories, maybe four. One is patients who had an insufficient evaluation. So that would be cryptogenic because we didn't find the cause, but not because that cause was unknowable, but because we just didn't look hard enough. Sometimes we have a really thorough evaluation and it's truly negative, and that's really the target. And how do we define thorough? And we'll come to that. But also multiple competing causes counts as cryptogenic. Somebody with atrial fibrillation and a carotid stenosis. And that is pretty clear what you should do with those patients is treat both. And so that's hardly worth a conversation, but again, confounds any kind of prior definition of cryptogenic stroke. And then there's this fourth group, which I'll call leftovers from the known categories that don't quite fit. And I'll give some examples of all of these. So here's just a case to kick it off. 68-year-old man with mild left face and arm weakness, mild neglect. He has hypertension, was a prior remote smoker. Neuroimaging shows this small right very cortical infarction. He has a carotid ultrasound that shows no significant stenosis. EKG is normal. Echo is essentially normal, and he has a mildly elevated LDL, but nothing in particular. So this is a pretty classic cryptogenic stroke. So how thorough is thorough? Well, this guy, he had a history and examination, carotid ultrasound, EKG, telemetry in the hospital, and an echo and a routine blood test. We found nothing. Are we done? Do we give up? Is that enough? And arguably, we've moved well past this. Patients should get intracranial vascular imaging. For a long time, people didn't do that at all, and then after studies showed that stenting didn't work and aspirin anticoagulation had the same effect, some people said, well, what's the point of even looking at the intracranial vessels for prevention purposes? Some of that's sort of become moot just by virtue of the fact that we do CTAs on everybody when they roll in the door now. So we're getting that intracranial imaging, but that was sort of a dark spot for a long time. And in places where acute thrombectomy is not an option in other parts of the world, that intracranial imaging is also not part of their workup. So it's critical. Does everybody need a transesophageal echo? Probably not, but it does fill in some gaps in some patients. And so, and that's sort of a long topic, but looking at the aorta, looking at the septum, looking at more detailed view of the valves could be really informative. Should everybody get prolonged cardiac telemetry? We'll come back to that topic. Extensive prothrombotic testing and then testing for the weird other stuff as well. So, where do you draw the lines? This is a bit nebulous and had not previously been well defined. It's weird. I guess so. Let me talk a little bit about this, the cardiac telemetry issue, because this comes up the most. It's probably like the best studied underlying cause of otherwise cryptogenic stroke or embolic strokes of undetermined source. So obviously biologically plausible that patients can have atrial fibrillation that is paroxysmal, intermittent, not immediately known at the time of the stroke, and could be the underlying cause of the stroke. But it's a real diagnostic dilemma because patients can have this intermittently. And if we have them on telemetry in the hospital for 2 days, we can miss a lot. We know that the majority of atrial fibrillation episodes are asymptomatic. Patients don't have palpitations, racing heartbeat, or anything else. And even in the patients who have known atrial fibrillation, persistent atrial fibrillation, the likelihood of having an asymptomatic to symptomatic run is more than 10 to 1. 25% of patients who come in with an atrial fibrillation associated stroke where we find atrial fibrillation in the hospital, have no known prior history of atrial fibrillation. And even in stroke patients with known paroxysmal atrial fibrillation, when they present with the stroke, they're for the majority in a normal sinus rhythm. So all clear evidence that we are missing some of this. Because it's intermittent, the longer we monitor, the more likely we are to pick up atrial fibrillation. We only see maybe 10% in that first day or two in the hospital. And if we continue to monitor patients beyond, we can see continued detection of atrial fibrillation. And the technology for monitoring for atrial fibrillation has really not been around for that long. The first study to really put this on the map was in 2008, so really not that long ago when you think about it, where wearing mobile cardiac outpatient telemetry for 4 weeks detected atrial fibrillation of any duration in about a quarter of patients. And there's been multiple studies since then suggesting that it's somewhere in the range of 5 to 25%, depending a little bit on what modality you use, which patients you choose, et cetera, and also what thresholds you use for your identification. But these were all, observational studies. The one randomized trial that really looked at this in some detail was called Crystal AF, where 450 patients with cryptogenic stroke were randomized to get a device implanted called Reveal. The initial ones of these looked about the size of a flash drive, and monitored patients for as long as the battery would last, so up to 3 years, and as long as they would follow up. But the primary outcome was within 6 months. And I'm stuck. Oh, there we go. Not surprisingly, we found a lot more atrial fibrillation in the patients who were monitored with the device than in those who were given routine care. The difference was about 9% versus 1 to 2%, six-fold higher likelihood of detecting atrial fibrillation. And again, this was clearly time associated, and that the longer we monitored patients, the more likely we were to pick it up. If you followed patients after 3 years, again, we lose some patients, but 30% versus 3%, suggesting that this is really a very prevalent underlying problem. Most of the atrial fibrillation in the study was more than 6 minutes, but still some was very brief. And the device will only really detect atrial fibrillation when it's there for at least 2 minutes. So this filters out some of the very, very brief atrial fibrillation that we see with some of these other patients. Again, the initial device was relatively large. The new one, as you can see, is literally like 1/20th of the bulk of the prior one. So I feel like one of my slides may be missing, but anyway, so it's pretty clear based on this that about 20% of patients with cryptogenic stroke have occult atrial fibrillation. Most of these are asymptomatic. The longer we monitor, the better. But the role of the short role episodes of atrial fibrillation is of uncertain significance, and the timing may be out of sync. And so we need to look at that a little bit more. And this is a really critical question of how much atrial fibrillation increases the risk of stroke. And is atrial fibrillation detected after stroke the same thing as atrial fibrillation known before? Back when the monitors were relatively new, here's one of my first patients. This is a surface monitor, not a device. And one of the first patients I ordered this on had atrial fibrillation described here as less than 10 seconds duration on day 21. And in a 28-day monitoring, that was the only atrial fibrillation detected. And I thought ding, ding, this is the answer. I should definitely anticoagulate this patient. And I did. Unfortunately, they're still doing fine. But you always wonder, how can you really even determine that an irregularity for 10 seconds is atrial fibrillation as opposed to something else? And if that's all you saw in 28 days, then is this really relevant? So I guess the top is cut off a little bit there, but this is an analysis from 2 of the clinical trials that looked at patients with atrial fibrillation to try to explore some of the issues about paroxysmal or intermittent atrial fibrillation as opposed to persistent or permanent. And these studies and others before them showed consistently that patients with permanent atrial fibrillation or persistent atrial fibrillation lasting at least 30 days had a higher risk of subsequent stroke than patients with paroxysmal atrial fibrillation. In all these cases, though, regardless, the patients who got anticoagulated did better. They had a lower risk of recurrent stroke. So that's critical. But clearly, these patients are variable risk depending on their atrial fibrillation burden. There's a study from ASSERT, which took 2,500 patients who had an indwelling pacemaker or implanted cardiac defibrillator. So these are patients who have some underlying cardiac disease in the first place, otherwise they wouldn't have had a device. But this tried to explore this question in a larger sample of where does paroxysmal or occult atrial fibrillation come in. So this isn't a stroke population per se, but a patient population where they're closely monitored. And they found that about 10% of patients had subclinical atrial tachyarrhythmias lasting at least 6 minutes during the first 3 months. And notably, the title of the article is Subclinical Atrial Fibrillation and Stroke. In the paper, they never actually say fibrillation, they say subclinical atrial tachycardia. So arguably these are the same thing, but maybe not. There may be some other like atrial somethings that are complex as well. But in any event, so they used this definition, and they found that the patients who had these subclinical atrial tachycardias were 2.5-fold more likely to go on to have a stroke than the patients who didn't have them. So this would suggest that the subclinical stuff really does matter, and it matters a lot. But again, it raises the question of what is going on in the atrium and how much of this is as black and white as fibrillation. Some other important observations are that, not surprisingly, the majority of the atrial fibrillation detected was brief. Here you can see that the proportion that was lasting more than 6 minutes was, by the end of follow-up, more than half of the patients. Conversely, the patients who had atrial fibrillation or subclinical atrial tachycardia for more than 24 hours was about 1/5 as much. So the duration varies a lot. And most importantly, when you look at the stroke risk in relation to this duration of atrial fibrillation, only the patients who had atrial fibrillation episodes of lasting more than 24 hours, the yellow line here, had an increased risk of stroke compared to all the others. So some would argue that, well, there you go, it should only be 24 hours and all this short stuff doesn't really matter. There is something sort of impossibly wrong with this slide though. And that is that you see that the jump, the risk in stroke is entirely like in that first month. And so this raises a lot of questions, sort of biologically implausible compared to like all other studies of atrial fibrillation where there's, a high risk, but it's a gradual, slow risk. It makes you wonder if some of these patients were hospitalized for a stroke and then their atrial fibrillation was detected for a longer period of time. If there's some confounding, there's something else that kind of doesn't really sit right. So while this is often used as uses the guideline for ignoring atrial fibrillation of shorter durations, it's really sort of problematic, and we really have not solved this issue. But you'll see this used a lot to assert, pun intended, that this is the rule. Okay, so we talked about atrial fibrillation. Let's talk about this leftovers from the known causes that don't quite fit. So in order to have a large vessel stenosis as the cause for your stroke, you have to have a greater than 50% stenosis atherosclerotic disease. And 50% comes from basically like the NASCET carotid endarterectomy trials, where we said that only patients with greater than 50% carotid stenosis benefit from, keeps doing that, but only patients with greater than 50% stenosis benefit from endarterectomy. That doesn't mean that only patients with greater than 50% have the stroke caused by that plaque. And here's just a great example of a patient who, if you measure this stenosis here, compared to the distal vessel, which is how you measure a carotid stenosis, that's 40%, maybe even less. But this is a nasty looking ulcerated plaque with a big hole in it. This is for sure the cause of this patient's stroke. So yes, this patient didn't fall into the NASCET criteria. What to do about this is debatable. You could still make an argument to do an endarterectomy or a stent here. But is this the cause of the stroke? I think it doesn't take much of a leap of faith to say that is the smoking gun. And even though that doesn't formally meet criteria. So this is sort of on one of those on the fringes. Similarly, the criteria for defining small vessel occlusive disease, or Lacuna, in existing criteria is that there has to be a small infarction, less than 1.5 centimeters, that is in the territory of a perforating artery. That was sort of arbitrarily defined based on sort of consensus data and some prior imaging studies. This is often sort of a perilous thing for radiologists, especially in places where non-neuroradiologists read imaging studies. So these were both called lacunes. This one is cortical. This one is in the insular cortex. This is a cortical infarct. There's no way this is a lacune. This is not in the territory of a deep penetrating artery. And this one maybe could still be in the territory of a lenticular stripe, but it's too big technically to meet that criteria. So again, we're like using definitions that are a little bit arbitrary, a little bit rigid, and you have to do that for the purposes of clinical trials, but for trying to understand the underlying disease, again, maybe this one is, but this one also could be an embolic stroke that just happened to travel up that branch. So we have to be careful about how we use those as well. But both of these were called lacunes, and I would say neither of them were. Then there's all these other sources of cardioembolism. So we talked about atrial fibrillation as a high-risk source. The things here in red are the high-risk sources. But in the original criteria, there was a lot of stuff that was in this sort of gray zone, again, more gray in the world of cardioembolism, such as congestive heart failure, patent foramen ovale, atrial septal aneurysm, as of somewhat uncertain role in the pathogenesis of cardioembolic stroke. PFO, patent foramen ovale, is arguably like a whole talk by itself, so I won't go into that in great detail, but I'll just remind everybody that PFO is a common cardiac abnormality, present in 25% of people, and is a potentially conduit for venous clot to cross through the heart and travel to the other side. If my video works, this is what it looks like on echo, where you can see this right atrium is filling with bubbles here, and then those bubbles shot across the septum. Let me run that back and show it one more time. Just for those of you who aren't used to looking at these things, you're going to suddenly see this big jet of stuff come through there. That's bubbles crossing through the PFO. There's been now multiple trials that have looked at PFO closure versus medical therapy, and the initial ones failed. And again, that's sort of a long talk, but all together, the 6 trials with increasing selectivity over the course of years led to this patient-level meta-analysis. 3 trials were positive, showing benefit of closure in their own right. This meta-analysis really kind of dives into some of the details, and this may be new to some of you. Here, again, overall, we show that medical therapy is associated with a much higher risk of stroke, that closure reduces that risk by a hazard ratio of 0.42, so 58% relative risk reduction, and an absolute risk reduction per year, or per 2 years, of 1.7%. When you think about PFO as a common cause of stroke in young people, particularly in like 30, 40, 50-year-olds who are planning on living for another 30, 40, or 50 years, that number really adds up substantially. And so we can do a lot of good in terms of stroke risk reduction. But we want to make sure we select the right patients. And so a system was proposed to try to better define which patients are most likely to have the PFO as the cause for the stroke, because PFO is ultimately like a relatively common congenital abnormality. 1 out of 4 people listening to this has a PFO, and most of them will never have a stroke, or at least not one necessarily related. So this PFO associated stroke causal likelihood system, or Pascal, was proposed initially in a kind of a paper redefining PFO associated stroke as a way to do this. And again, at the time that we published this was really just a proposal. And we said, if you had a high ROPE score, I think I'll show ROPE in the next slide, but ROPE score is you guys are probably familiar, a scale where it goes from 0 to 10, where 10 represents patients who are young with basically no vascular risk factors and a cortical stroke, and 0 represents older patients who have hypertension, diabetes, smoking, or a subcortical stroke. And so therefore, the patients with 7 to 10, the high scores, are the healthier population, more likely to have the PFO as the underlying cause of their stroke, and the lower ROPE scores are not. And then we took high-risk PFO anatomy, meaning that the shunt was either large or they had an atrial septal aneurysm, a floppy septum between the 2 sides. The patients who had both of those things were considered probable PFO-associated stroke. Patients who had either one were considered possible, and patients who had neither were considered unlikely. Again, if you don't have high-risk anatomy and you're an older patient, less likely. But honestly, we kind of made this up at the time as a way to create a framework for understanding this disease, but didn't have the data. This individual patient meta-analysis really helped us here. So first, we just looked at ROPE, because ROPE was well established, and showed that if you use ROPE scores, the patients who have a score greater than 7 have a dramatic reduction in stroke risk. The patients who had a score less than 7 also seemed to have a reduction in stroke risk. It's sort of just cross 1. But most importantly, in both of those groups, it looks like it favors closure. There's a difference between the groups, but it doesn't really help us decide who benefits and who doesn't, because by ROPE score, looks like everybody benefits. Keeping in mind that this is not like everybody, but everybody who was in the trial. So these were already a highly selected patient population. However, when you look at the Pascal score, here, the patients with a probable score had a 10%, well, 90% relative reduction, a hazard ratio of 0.1, patients with a possible 0.38, and the patients in that unlikely category, who were again enrolled in trials because somebody thought that they were a reasonable candidate, they did not benefit. They had no net effect of closure. And this p-value for interaction suggesting that these three are all indeed different is highly significant. So this really does help with the risk stratification and trying to decide who's most likely to benefit and who's not going to benefit from closure. Again, keeping in mind that these were all patients who were enrolled with the idea that the PFO was the cause of their stroke. So they tried to enroll the right patients. Turns out 15% were in this unlikely category, and that is really striking and should help us select better for clinical practice. The other kind of thing that was hugely striking to me was when you look at the risk of post-procedure atrial fibrillation, which is the biggest concern with PFO closure in the first place, that something in the range of like 2% of patients will have AFib after closure, which, by the way, the vast majority of that is very short-lived. Only about 1% of patients will have persistent or prolonged AFib beyond the procedure. But the Pascal score helps distinguish that as well. So the older patients with smaller PFOs are very much higher risk of having post-procedure atrial fibrillation, whereas those in the probable category are young, healthy hearts and young, healthy patients, a low risk of atrial fibrillation. And so not only do we identify with this tool who's most likely to benefit from closure, but also who's most likely to be harmed. And this hopefully draws some lines in clinical practice as well, and guidelines are just starting to catch up to incorporate this. Okay. So what is cryptogenic stroke, and how does this help us drive our therapy? Well, again, if it's an insufficient evaluation, we need to look harder. If it was a thorough but negative evaluation, are we sure it was really negative? Are we including those leftovers from the other categories that don't quite fit? And then again, we can probably ignore the multiple competing causes. So in 2014, a group of people got together to say, let's try to define a category. Sorry, this top line is frustrating, but this says embolic stroke of undetermined source. A group of people got together to try to define this really for the FDA. So the new anticoagulants were coming out. We were thinking that a lot of these embolic strokes of undetermined source might be due to occult AFib or occult hypercoagulability or something else. Could we treat these patients like we treat cardioembolism? And the FDA said, well, you can't have cryptogenic stroke as a future indication for your drug because we don't know what cryptogenic stroke is by its very name and nature. You need to define something else. So ESUS came up by consensus as a way to at least, again, create some diagnostic criteria. And the criteria that we came up with, again, made up at the time, were patients had to have an embolic appearing stroke, either cortical or large, not lacunar. They had to have absence of intracranial or extracranial athero, again, using 50% arbitrarily. No major cardiac source of embolism, including atrial fibrillation, prosthetic valves, et cetera, didn't exclude PFO. And then they had to have no other specific cause of stroke identified, like vasculitis or dissection or that sort of thing. And those were the criteria that were used. More recently, in late 2022, a paper published in Nature Reviews of Neurology kind of tried to update the definition of ESUS. I don't know if everybody's seen this, in response to Pascal and PFO. And so now PFO associated stroke and Pascal probable or possible should be excluded from ESUS. So we've narrowed that a tiny bit, but not really a lot. When you go back and redefine strokes in this population, instead of having 30 to 40% of patients using the ESUS criteria. Sorry, somebody's not muted out there in TV land.
Little garbage cans, just have a big amount if you need one. Wow.
Okay.
Oh, okay, but I didn't know if you had any like
I don't know how to unmute
that
them.
sort of stuff.
Hello
like,
out there in TV
hardware,
land.
Anything that can't go in the receptacle.
Anybody recognize that voice?
Because this is just shredded, right?
Well, this is old journals. I don't know if they need to be shredded.
Let's see. Was there? How do I?
Here, sorry.
What's the best thing?
Well, that's fine for that. Yeah.
Yeah. Okay.
Yeah, but any type of garbage.
Oh, Don.
It's John Sanders, guys.
Yeah.
Okay. All right. Sorry about that. All right. Back on track. Thank you very much. So anyway, so using these criteria, we can knock this this category of cryptogenic stroke from about 30-40% down to about 16%, and that's actually been looked at across multiple countries, and that seems to work. It's still a big chunk of patients that we don't know what's going on with them, and still leaves us with the question of what to do. So let's try to take, again, a deeper look. Well, if you take the clots out of patients with thrombectomy and look at, and then ultimately decide like what category are they in? Are they in this ESUS category or a cardioembolic stroke or large vessel stroke? It turns out that in terms of the distribution of red cells, white cells, fibrin and platelets, that the undetermined sources and the cardioembolic sources look a lot more alike than do the non-cardioembolic sources. And this is from 2 different studies that kind of gave similar results. So pathologically similar. Some studies are now being done with kind of more biomarker testing and even electron microscopy to try to get a better detail on this. But overall, at least grossly, they look quite similar to cardiogenic emboli. So we're still stuck with that. And so this again led to a couple of trials to use the shoot first and ask questions later approach using the new anticoagulants. These trials were built on preciously little prior data from WARS. WARS was a trial done in the late 90s, maybe into early 2000s. Published in 2002 initially, where patients with a mix of strokes, was basically not AFib and not carotid, were randomized to warfarin versus aspirin, warfarin being the anticoagulation around at the time, about 2,000 patients. And overall, no difference, not surprisingly, which is why we're not using warfarin in our routine practice. But a post hoc paper published several years later looked at the patients who were defined as cryptogenic stroke, and then looked at their infarct topography. And so patients who had non-lacunar strokes, either superficial, cortical, large, whatever, had roughly 1/3 less stroke if treated with, actually this is stroke and death, but still similar for stroke, 1/3 less recurrent risk if they were treated with anticoagulation versus aspirin. But you can see there's a very small number. It's only 340 patients, not statistically significant, but still like sort of a tantalizing finding that suggested that maybe anticoagulation could be effective in this group. This led to 2 large clinical trials, Navigate and Respect ESUS. Navigate was a trial of 7,200 patients randomized to rivaroxaban versus aspirin. The doses were rivaroxaban 15 milligrams, which was a little bit less than the atrial fibrillation dose, thought to be sort of a margin of safety for our older stroke population. And the aspirin dose was 100 milligrams once daily, which is the most commonly used dose worldwide. The trial was halted after enrollment was completed, but before follow-up was based on the data monitoring committee saying that there was a risk that outweighed any chance of benefit. These were the primary results showing no difference. Most importantly, these patients are at high risk, 5% risk at 1 year with either therapy and no clear benefit. And again, we really have very little follow-up beyond a year here with mean of 11 months. Around the same time, the Respect ESUS trial was going on. This was using dabigatran, similar design, 5,300 patients randomized to dabigatran versus aspirin. And here also no significant benefit of dabigatran versus aspirin, although there is, because this trial did go to its full completion, there is this apparent divergence later in the course, maybe after about a year and a half, where maybe dabigatran is associated with lower risk. And it's maybe in part due to, we don't have a lot of follow-up out there, but there's been a lot of speculation about what happens out there. Is this that as the patient population gets older, there's more atrial fibrillation and then dabigatran has a bigger chance of having a benefit, or is this just, chance? There also seemed to be a bigger benefit in the people over 75, again, supporting maybe this atrial fibrillation question, but doesn't really prove it. So after these 2 big trials failed, we kind of descended into darkness. We had all these great ideas about what ESUS is. We defined it better. We found atrial fibrillation. We understood the clots, and yet these trials failed. So why did it fail? So some would argue that four Ds equals 1 big F for failure. The Ds being the design, is the ESUS concept dumb? Did we use the wrong drug, wrong dose? Did we need a dual therapy? Maybe patients needed a combination of anticoagulation and antiplatelet therapy. Were the doctors dumb? Did we enroll the wrong patients? Was this really the right ESUS cryptogenic population? Did the data safety monitoring board abort too soon and that's what killed the trial? Well, that's what we were thinking about when Navigate stopped. But then after Respect came, we probably can throw some of those out. It probably wasn't the wrong drug, wrong dose, because we had 2 drugs tested in different doses. Probably wasn't the doctors, again, 13,000 patients, it's probably not all wrong. And it wasn't the DSMB because the second trial went to completion. So it leaves open the questions of whether or not just the ESUS concept is dumb or can we do better? So we learned these patients are at high risk of recurrent stroke, again, about 5% in both arms. that ESUS is probably more heterogeneous than we thought. We cannot shoot first and ask questions later, and we really need to define this, redefine this definition, or refine this definition. And then we need to, keep looking for other explanations. So we want to dive back into ESUS, and it's pretty heterogeneous, and there's a lot of parts to this. And we were for sure overly simplistic in our approach to try to define these trials. It seemed like a quick and easy answer. Obviously, the companies that made anticoagulation new drugs were very excited to have a new indication, but we kind of failed them. So, what are our leading contenders here? Well, paroxysmal atrial fibrillation still looms. Atrial cardiopathy, I'll come back to. PFO is probably like out. Cancer is emerging as patients are living longer with cancer. We're seeing more and more strokes, and that the epidemiology suggests that could be really a major factor here. And then we learned something during the beginnings of the COVID pandemic, where maybe viruses are a transient factor that could be contributing to what was otherwise considered cryptogenic stroke. Still a lot of debate about how much COVID really increases the risk of stroke, but we did see it early on, again, not so much later in the pandemic as the isotypes changed, but maybe that's a factor in why some of these patients are at high risk of recurrence and some are not. So we need to move beyond our ESUS definition. Well, let me just step back to PFO for a second. So we said PFO-associated stroke should be taken out of ESUS. Well, that's true for the under 60 population who has these other features, but we really have very little data about PFO in the older population. These trials gave us an opportunity to look at this. And in Navigate, where the average age is like 68 and there's very few patients under 60, there were a lot of patients who had PFO, not necessarily attributed to as the cause of their stroke, or they may not have been in the trial, but who had PFO nevertheless. And in this group, it looked like the treatment with an anticoagulant reduced their risk of stroke by about half. When you combine this with the prior trials that looked at anticoagulation versus aspirin for PFO, there was an odds ratio of 0.68, not statistically significant, but maybe favoring anticoagulation. And so there may yet be a role for anticoagulation in PFO. It is ultimately due to venous thromboembolic disease that traverses the PFO. So it sort of makes sense. More is coming on this topic. And maybe for patients who are older, who are at higher risk for procedural related atrial fibrillation because of the device, this is a viable option. I just found out that France just approved a trial called CLOSE-2, where they'll be taking people over 60 and randomizing them to antiplatelet therapy, anticoagulation, or device closure to try to get at this. Something that we tried to do in the US and seemed like there were too many logistic barriers to having that happen here. An emerging area is atrial cardiopathy. So the idea here, kind of going back to what we were talking about, atrial something, right? It's not just all about atrial fibrillation. But atrial fibrillation is probably the end manifestation of an atrium gone bad. And the atrium gets stretched and stressed as we get older, sometimes on a genetic basis, sometimes age-related or alcohol or other things. And if the atrium is dysfunctional, then clots can form there, and it doesn't necessarily have to fibrillate. There's good evidence that patients with frequent premature atrial contractions and high burden are also associated with a subsequent risk of stroke. Patients with a large left atrium have a higher risk of stroke, and patients who have a large negative P wave terminal force on their EKG. For those of you not used to looking at EKGs, that's what we're talking about here. Here's a P wave, and sometimes it's kind of biphasic. There's a part that goes below the line. And if this is a big area below the line, that's a sign of left atrial dysfunction as well. And is associated, all these things are associated with subsequent risk of atrial fibrillation. So the Arcadia trial, NIH-sponsored trial led by Houman Kamal at Cornell, has been randomizing patients who have ESUS and evidence of atrial cardiopathy to anticoagulation with apixaban or aspirin. Here again, atrial cardiopathy was defined by either an enlarged left atrium on echo, this P wave terminal force, or a high NT-proBNP, brain natriuretic peptide hormone elaborated by the left atrium in a response to stress. It got terminated recently. We'll see the results hopefully next month. Unclear if it was terminated for efficacy or safety, so we don't really know. But this is obviously a high contender for a potential cause of stroke. We did try to look at this in Navigate. Again, we had 7,000 patients. We tried to learn as much as we could from this study. And here, in the patients who had an enlarged left atrium at baseline, who were treated with aspirin, they had a very high risk of stroke, far higher than the patients who had a more normal sized atrium. And in this group, patients treated with the anticoagulant rivaroxaban had a substantially lower risk of stroke, almost 75% less. So this again would suggest that Arcadia ought to be positive. However, this uses echo, and it turns out that in Arcadia, less than 10% of patients were enrolled based on a large atrium on echo. It was mostly based on the other two criteria, the P-wave terminal force or the NT-proBNP, and we don't really have that data from Navigate or Respect to look at it. So maybe that echo is the driving factor. Again, more to be learned hopefully next month. The one other group of interest from Navigate was the patients with left ventricular dysfunction. So left ventricular dysfunction has been a topic that's been studied extensively in patients with really severe heart failure, very low ejection fractions, less than 30%. They're at such high risk of progressive heart failure and death that it's really hard to show benefit in this population. A couple trials showed that anticoagulation reduces the risk of stroke by half in that population, but again, they're so much more likely to die of their heart disease that it didn't really make a dent in the sort of composite outcome. In Navigate, where we had sort of a less sick population from a cardiac perspective, we looked at those who had an EF of less than 40%, mostly in that 30 to 40% range, or a regional wall motion abnormality. And again, here found that that group was at substantially higher, that's the light blue top line here, Carolina blue, looks bad. This is the group that has the highest risk of subsequent stroke, recurrent stroke. And if patients were treated with rivaroxaban instead, they had a markedly lower risk. And so that would suggest that this probably is a cause of stroke in this population. Again, one of our ESUS subgroups that really matters, and one that we could potentially treat if we can prove this further. And so a trial has been proposed to NIH StrokeNet to try to answer this question. We'll see how this fares in review. I think this looks very promising. Okay, I mentioned this one before. This is this patient with 40% stenosis, but we really need to better understand plaque and not use stenosis as our only criterion. This has also been a very active area of research, and it's not really just about stenosis. There's good evidence that intraplaque hemorrhage, which you can see on MRI, is associated with a high risk of recurrent stroke. There's some evolving evidence that complex calcific atheroma, so here's calcification, you can see it's very heterogeneous. There's like a hole here and here. Some are maybe more homogeneous, some are more heterogeneous. That may be a predictive factor in subsequent risk, and again might help us define like which patients, even with less than 50% stenosis, might benefit from some sort of treatment, whether that's surgical, endovascular, or medical, to be determined. And there's even some work with PET scanning where you can show hypermetabolic plaques where they light up, suggesting that they are very active. So we're trying to image really small area of biology, but studies have shown that all these features are associated with substantially higher risk, potentially fivefold higher risk. And so something we need to understand and explore, and not just blow off based on 50% as a arbitrary threshold. Lastly, I just want to say a few words about cancer. So we've all known about hypercoagulability of malignancy since the time of Trousseau and probably before that. And a lot of people have some pretty hard and fast notions about it, but it's actually a pretty complicated idea. Cancer patients, particularly those with advanced stage cancer, are at higher risk of subsequent thromboembolism and stroke. But it's really hard to sort out which cancers, which patients. There's no good biologic test for this. D-dimer maybe helps, but it's far from perfect. And so we really can't prove that cancer is a definitive cause of stroke, although they're at higher risk, unless we can prove that we can treat that hypercoagulability and reduce it. There's been a lot of discussion about whether or not the cancer is the cause of the stroke or the chemotherapy. And this Catano study was a huge driving factor in this. So there was multiple studies suggested that maybe it was really about the chemo and not the cancer. And here, if you look at this top left graph, this is kind of unadjusted risk of stroke risk in patients treated with chemo in blue and not chemo in red. And it looks like chemo is the source of the stroke rather than the cancer. But in fact, when you really adjust for cancer status in particular, so the severity or stage 3 or 4 cancer, that risk related to chemotherapy entirely goes away. Conversely, if you look at advanced cancer here in blue versus not advanced, so again, stage 3, 4 versus something else, that persists when you account for all other stroke risk factors, chemotherapy, et cetera. So it really seems that cancer is the answer, not the chemotherapy. And so we need to treat this. a small pilot trial by Babak Navi, also at Cornell, it was very tiny. 20 patients got randomized to anticoagulation versus antiplatelet therapy to just sort of see, are patients willing to do this or doctors willing to do this? And the answer seemed to be yes. This population is at huge risk, not only of stroke and other venous thromboembolism, but also of hemorrhage. It's a super complicated population. So we've pitched a trial to NIH that this did very well in review. It's back under for its second round. We're hoping that we can do this trial. And again, I think a lot of people go into clinical practice with the idea that cancer is the cause of their stroke. We should anticoagulate all these patients. If this trial comes along, I would really encourage everybody to participate because I think we really need to better understand who and why and when and where. So this is really where we are. These are the final frontiers of trying to understand the mechanisms and the treatments for cryptogenic stroke. And I may have overdone it with my Star Trek analogy. So I tried to put this in a format that everybody at Duke will resonate with as we try to figure out what are the predominant causes and what we can do to treat them. And I will stop there and take any questions. Thank you very much. I'll put this back up because I like it. Should I click on this chat and look at the questions here? Yeah, okay. All right, so let's see. So in comparing aspirin to anticoagulation, you said a lot about stroke prevention, but not much about the downside of anticoagulation or hemorrhage. That's true, really, because I was trying to explore more about the underlying mechanisms and potential efficacy. There's no doubt that we are concerned about hemorrhage. It turns out, so some weird things happened, particularly in Navigate and Respect. So Navigate, the risk of bleeding on actually, I might even have this as a hidden slide. Let me see if I still have this here. Bear with me 1 second. Yeah, I love this slide. Whoops, no. All right, well, let's see if I can just pull it up this way. So this is this weird thing that happened in Navigate and Respect. So in Navigate by itself, the risk of bleeding on anticoagulation was about 3 or 4-fold higher than it was on aspirin here in light blue. We didn't see this in the Respect trial of dabigatran versus aspirin. We didn't see this in the Averroes trial, which was a trial of apixaban versus aspirin. The most striking thing here is that the risk of bleeding on aspirin and Navigate was shockingly low, well less than every other prior trial of aspirin in stroke patients. And so it's sort of hard to know. So there's clearly some excess of bleeding with anticoagulation versus aspirin, but it looks like it's probably on the order of less than 0.5% overall. Other trials have borne this out. This may have been an aberrancy, but ultimately, for sure, we need to prove not only that these therapies are effective, but also safe, and that is unquestioned. So again, we'll see what happened in Arcadia with that both risk and benefit, and hopefully in the proposed Resolve trial as well of the patients with left ventricular dysfunction. All right, let me go back to our chat. Whoops. I lost the chat. Oh, there it is. All right. And a pair of clapping hands. Thank you very much. Yes, go ahead.
Yes. So Apple applying to the FDA and trying to use their device as a monitoring tool. Is that something that's being employed in a way that can continuously detect for AFib? And when we talk about the short duration AFib, or especially AFib that are detected over the course of a year, how does that accurately predict in terms of being a causal factor to cryptogenic stroke?
Yeah. So the two questions were where does the Apple Watch fit into all of this and other sort of wearables, and then how do you look at burden of atrial fibrillation over the span of say a year as opposed to just individual durations? So the Apple Heart study was sort of interesting. So this was a voluntary study where people who had Apple Watches signed up, sent in data. There was a huge false negative rate, lots of people who had stuff that the watch detected as possible atrial fibrillation, which then was adjudicated by experts, and less than I forget what the number is, but a small percentage of it actually was atrial fibrillation. So that was probably about 5 years ago. The technology's probably improved still. It's good at detecting irregularity. It's not so specific about detecting atrial fibrillation. But I do think like that, this is probably where like our world is headed, right? We're using these implanted devices, but we could probably use less invasive things. Can you really tell well enough on the wrist, like what the exact rhythm is and that sort of thing, I think is still questionable, but optimistic. So again, I think we're not quite there yet. We probably still need to use like something dedicated close enough to the heart to actually see what the rhythm is, the electrical conduction is within the heart. As far as the burden goes, this is a huge still question, right? It's hard to analyze and hard to really get this sort of duration of data. There are a couple of trials in the US and in Europe that are trying to look at exactly what you asked about atrial fibrillation burden and can we use this to detect. Ultimately, the proof in all this is going to come not from observational studies showing a correlation between duration or burden and risk, but really one of like, if you anticoagulate patients with whatever data you have in front of you, short duration AFib, small burden AFib, do they actually benefit more than have risk of bleed from anticoagulation? So, and this is a tough question, right? If you had a patient who had a stroke and you found 5 minutes of atrial fibrillation, so I don't know what to do with them, and there's a trial that's going to randomize anybody who has less than 24 hours of atrial fibrillation, would you randomize that patient? And you might say, I don't know, because up until today, I was anticoagulating them. Now you want me to randomize them, but that's a big change in my practice. And will the patient who you say you have atrial fibrillation, it's only 5 minutes. We know atrial fibrillation is a risk factor for stroke. We know anticoagulation benefits, but I'm not so sure about 5 minutes. Do you want to participate in this trial? How many of them are going to say yes? So there's a study for everything. And so there's a study ongoing to see like what proportion of patients and their clinicians are willing to randomize to try to get to these issues. But it's super complicated design because equipoise for a lot of people has kind of gone out the window. And then how do you get them to get the trial done? Okay, yes.
You talked about TEE as part of that process. In your clinical practice, do you use cardiac MRI at all, or is there any utility in using cardiac MRI with TEE?
Yeah, so the question was, how TEE versus cardiac MRI versus either, both, neither in diagnostic testing, and this is yet another area where like we really don't have a ton of research to guide us. There's decision analyses of various quality suggesting that TEE helps in our decision making, but if you have somebody who's 75 who has like a slightly negative P wave force or whatever, you might think, well, they're more likely to have atrial fibrillation than they are to have an atrial myxoma. So like what you might monitor them first and then say, well, if I don't find anything, maybe bring them back into a TEE. So again, like the best optimal order for doing this is really challenging. I think there's still a lot of clinical gestalt in this probably, and like, again, younger person, you might be looking harder, you might be more inclined to say, do they have a PFO, do they have a papillary fibrillastoma? Should I do it? I'm more likely to do a TEE early on because they're very unlikely to have atrial fibrillation. In an older patient, I'm more likely to do cardiac monitoring first and then bring them back for that. As far as cardiac MRI versus TEE, we're also used to MRI being so much better than everything else for the brain. But for the heart, it's really not so clear that we're getting a lot. There's been a lot of interesting things looking at a little bit more about LV structure. There's some weird stuff like non-compaction cardiomyopathy, those kinds of things where maybe we start to better understand what's happening there and maybe get a better handle on additional sources of cardiac embolism. But again, I think that's still a work in progress. So those are still great areas for ongoing research. But I think transthoracic is probably still standard for most TEE in selected patients, cardiac monitoring for people over 60, maybe 55. But you can throw the kitchen sink at everybody, but I think in trying to be efficient, that's probably still a reasonable strategy. Okay, somebody asked a similar question about that. Somebody asked about D-dimer for decision making, and so we actually tend to use D-dimer at baseline as sort of a screening test. Again, it's certainly not perfect. You can has sort of problems with both sensitivity and specificity, but D-dimer is greater than 2 or 2000, depending on what your assay calls it. Does seem to be associated with a higher probability of having some kind of underlying hypercoagulability, and maybe helps lead you down that path. So it's a reasonable screen. D-dimer is also elevated in patients with cardiac disease. So maybe points you a little bit harder there as well. Yeah.
You know, the real life implications. Do you define these plaques better with MRIs, look at plaque morphology? Sometimes we do MES, so microembolic signal detection, and then convince vascular surgeons to operate on this. What do you do in your practice to define these better?
Well, I mean, if somebody just had a stroke, then to me, like the MES probably is like a little over the top, right? Because like all you're doing is showing them like not only did they already have the stroke, but they're still throwing stuff. We've been using a lot of vessel wall imaging, so some advanced MRI to try to figure out like who's high risk plaque. Again, for clinical purposes, this is really like pie in the sky, right? I think we don't have enough data from those to say you should definitely do intraplaque MRI, looking for intraplaque hemorrhage on MRI, or using vessel wall imaging for looking for vessel wall inflammation or those things. I don't think we're there. From a research perspective, hugely interesting. You guys are a research institution, as are we. So keep looking. Hopefully, in collaboration, we'll all find better ways to identify these patients. For me right now, the only patients like with a less than 50% stenosis who would get an actual intervention would be somebody with a really nasty looking plaque. Again, not based on stenosis, but more just based on the morphology. Yeah, exactly. All right. Well, thank you all very much. For those of you up in Boston, enjoy AAN, and I hope to see you all soon. Thanks again.
Thank you.
All right. Can close that. I think we can
Are you
close
taking
it.
this to the working?
Oh, there we go. All right. I think I got all the questions.
Yes.